You have to take all those questioning. Anybody suffering from any bad disease like malignancies? Okay, also you can take the history of UTI, PID, occupation, all those things. You have to take the history. Okay, then patient is on the bed and you are talking. Then physical exam with permission. You're gonna have the gloves on and you will ask the patient, okay, I'm going to do, is it okay if I palpate your lower abdomen, body parts? Oh yes, I have no. But make sure you cover up nicely. You cover up nicely. Only this lower abdomen is open. Patient's modesty. Physical examination, you will do like an inspection. Then you're going to do the palpation. If you want to do the auscultation, you can do, but that's in inspection and palpation is good. And ask for any pain, any pain, any pain. Okay, so it is done. Why you are taking all those history? Because you need to understand the chief complaint. Patient gave the chief complaint and is written on the requisition. Sorry, requisition. Okay, sorry for the mistake. Requisition. I believe requisition. Okay, in the requisition it is written that why the patient is here for. Then on physical examination you are trying to get that any sign you can get it. And you are looking for any correlated symptoms. Okay? So that's why you are doing all those things. Then when you're done with the physical exam and inspection and palpation, so then by this time you will explain the procedure. You will explain the procedure, how you're going to do this examination. If it is only transabdominal, mention that. If it is both transabdominal and transvaginal, you have to mention that. If it is only translabial, you have to mention that. Okay? So, explain the procedure. Sometimes patient may not understand. It's a language barrier. So every time what you are asking patient is saying, What is this? That means whatever you explained to her, she did not understand anything. So now you ask patient, did you understand what I am saying? Tell me, what did you understand? So then you have to realize, oh my God, patient didn't understand that I'm going to send the transducer through the vagina. Oh my God, I didn't start yet. So then you realize, then you need help. Those who are the same language and is a hospital recognized people, not the patient's relatives, not your relatives. Hospital designated person, also known as interpreter, will come and will take care of everything. Then patient will say, okay, yeah, I have no problem, do this, or no, I don't want that. Okay, you could be very satisfied. Explain the procedure. So by this time, you will set up the transducer. Transducer selection according to the types of ultrasonography you are going to do, according to the indication, findings and expectation, transducer selection. And I just make it 3 things. It could be different patient to patient. Then patient's position. Get the patient's perfect position. If you want to do the transabdominal, so just patient is in supine position. That's it. Hands are by the side. Expose the area, exposed and supine position, you are scanning through the bladder. But if it is transvaginal, the patient would be in lithotomy position. Lithotomy position, okay? Lithotomy position, just like a GYN position or labor position. Okay, when the patient position is there, make sure you will cover up from waist to down, including the leg, with a big linen, so that nobody can see the private parts, even though you don't see the private parts. If it is a transvaginal ultrasonography, and if it is a translabial ultrasonography, you have to drape the body parts so that nobody can see it. Okay, so now patient took the position. If it is a transabdominal, so it's fine. You will use the curvilinear transducer through the bladder, and you're going to start. How are you going to start? Swipe the area. Swipe the area both or survey. Swipe or survey both in sagittal view and transverse view. Why swiping? Because before taking the actual protocol picture, I like to see those organs, are they easily visible? Or if they are visible, is there any pathology I can see? Oh, one more thing, that we need to see also the cul-de-sac, especially the posterior cul-de-sac or pouch of Douglas. Swiping that area, that includes the pouch of Douglas too. I like to see all those parts that I mentioned before, is all those are fine or bad in a glance. At a glance of maybe 30 seconds is enough. Just swipe 2-3 times. Just sagittal view and transverse view. If there's a pathology, you saw it, there is a peace of mind. Yes, I will get it. If you see during the swiping both ovaries are seen, it is a peace of mind. Yes, I will get both the ovaries. Okay? It's a peace of mind. When you swipe the area, then swipe both sas and transverse and instruct the patient. Instruction. What is the instruction? If you feel pain, discomfortness, so please let me know. I can stop the ultrasonography anytime. I can. And I will not be authorized to let you know the findings or discussing about the diagnosis, because I am not in that position. Okay, in this country, sonographers cannot diagnose the case and cannot discuss with the patient about the findings. Make sure you instruct the patient before. Otherwise, patient will ask you so many times, it will interfere your attention. Okay, so then number 13, start the protocol images. How are you going to start the protocol images? You will go one by one. Okay, for the uterus, you will complete the uterus. Then you're going to touch the ovaries. You will complete the ovaries. Then you will look for the adnexa. Okay, so now I will discuss about the protocols of the uterus, ovaries, and the vagina and adnexa. So make sure you understand and it fulfills your goal and objectives. Okay, so now I like to clean this part because I need more space. Okay, before going into the protocol images, I like to give you the orientation first. Okay, image orientation. So then you will create the image, you will be able to read the image. Okay. Image orientation. Transabdominal, SAS view and transverse. SAS view and transverse view. In sagittal view, it would be anterior, this would be posterior, this would be superior, and this would be inferior. In transverse, the anterior and posterior will remain the same, and this would be right and this would be left. Okay, so this is transabdominal, SAS and transverse. So now if we do the SAS, that means SAS means what? SAS means the longitudinal view, and transverse means the cross section. So let me draw one diagram. This is bladder, this is uterus, this is vagina, and this is rectum. Okay, you will get this view in sagittal. Look at here, in sagittal, see, bladder is anterior, rectum is posterior, and the uterus in the middle, behind the bladder and anterior to the rectum, it is. The fundus is anterosuperior, so fundus is anterosuperior, and the cervix is posterior-inferior. Cervix is posterior-inferior, and vagina is more inferior. Okay, it corresponds with the organ. In transverse, transverse means the cross section of this. So you will see in transverse, you will see the uterus here, and if you want to see the bladder will be here, and if you see the rectum will be here. So this would be bladder, this would be uterus, and this would be rectum. Okay, it corresponds. So now I will draw the transvaginal. SAS and transverse. In SAS view, transverse, in transvaginal, okay, as I said before, let me make it a little short. It is a very wide image. The orientation, this would be anterior, so automatically it would be posterior. This would be inferior, and this would be superior. Okay, for transverse, so this would be let me say, inferior, superior, this would be right, this would be left. Okay, so now if I draw the diagram, how does it look like? Okay, you will see the uterus. In this orientation. See, the fundus is anterior superior and the cervix is posterior inferior directions. And this is the view for the anteversion. Anteversion. And for the retroverted, it will be in this way. Okay? Retroverted. If I draw the retroverted with a different color, so this is anteverted. And this is retroverted. In retroverted, the fundus is towards the rectum, right? Posterior, towards the posterior. And in anteverted, the fundus is towards the anterior. Look at the orientation. And in transverse, you will see the uterus. Okay, so this is as usual, right and left, right and left. Okay, so this is the orientation. Most common orientation is transabdominal and transvaginal. And if you do the translabial, so labial will be anterior, posterior, superior, inferior, because you are using the curvilinear or linear sequential. So let me draw that one. Translabial. You can use curvilinear or you can use linear sequential. This would be anterior, posterior, superior, inferior. This is curvilinear transducer, and this is linear sequential transducer. So this would be anterior, posterior, superior, inferior. Okay, both of them are SAS view. Okay, and in transverse view, anterior, posterior, right and left. Same thing here in transverse view. Anterior, posterior, right and left. This is trans views. Okay, I hope you are understanding the image orientations. Okay, you got it. Now I'm giving the protocol images. protocol images name. Protocol images. GYN for transabdominal and transvaginal, all protocol images names are the same. Okay, the first of all, number 1, SAS uterus mid. Okay, I'm going to write down 1 and 2. SAS uterus mid with or without measurement. The first image we will take without measurement, and the next image we will okay, let me do one thing, not making complex. Image 1, SAS uterus mid, just mid. SAS uterus mid with measurement. Which measurement? Length and height. Length and height of the uterus. Number 3, make sure when you get the SAS uterus mid, it must show the endometrium. Now SAS endometrium. Number 4, SAS endometrium with measurement, the thickness. Thickness. Okay, let me show you these two images. If this is the image, so then you will measure from here to this for the length, and the height from here to there. It must cut 90 degree. It must cut at 90 degree. Then your measurement is perfect. And you have to take the longest and the heightest.